There's a lot of things in bipolar that can mimic ADHD. If someone is in a clinical major depression, a lack or difficulty concentrating is a hallmark feature of major depression. When someone is manic, they get hyperactive, they get impulsive, they get distractible. That is a hallmark feature of mania and may not be ADHD. Now, if I were to choose what is the biggest differentiator between ADHD symptoms and, hey, is this bipolar? Is that bipolar episodes are episodic.
Correct.
If they are hyperverbal, butting into conversation, distractible, cannot concentrate, fidgety, can't sit still, as far as like a bipolar mania or hypomania, that is an episode. Also, what you find to differentiate bipolar mood episodes from ADHD is the mood component. There is a fixed clinical mood, whether it's majorly depressed, hyper irritable, super euphoric, that you don't see in ADHD. ADHD is not episodic. There's not some sort of clinical fixed mood disorder accompanying it. And it's pervasive usually in somebody's life. Again, the episodic nature of bipolar and the accompaniment with a mood episode is two of the biggest ways I differentiate between, are these ADHD symptoms or is it secondary to bipolar?
And that's critical, I think, differentiating, something that is chronic in nature. I always have problems with, impaired concentration, organization, completing tasks. I always have, hypersensitivity to, negative appraisal or judgment by other people. Or during this period where I'm feeling significantly sad or significantly energetic or euphoric, is that unusual in nature? I think is critical to determine.
Yeah, absolutely. So if you feel like you have ADHD or bipolar or both or anything else, it really behooves you to sit down with a skilled psychiatrist who can get some diagnostic clarity. Now, I know this isn't available to anyone. Unfortunately, finding and sitting down with a good psychiatrist that cares, that is competent and educated and can sift through these nuanced differences is a luxury. I recognize most people don't have that luxury, but you really, really need to get diagnostic clarity because being misdiagnosed as either can cause significant problems in one's life.
It certainly can, and ensuring that before, a psychiatrist prescribes a medication, that a diagnosis is accurate is critical. And certainly many people will come to me that have been on medications, have prior diagnoses, that, don't make sense or are not accurate, medications that are not helping them. And at times it may be important to go back to the drawing board and really carefully consider. And I always encourage as people, come in for an assessment for, symptoms of cognition, that, a lot of people come into the conversation with, some biases perhaps, with a preconception, with a notion, with a prior diagnosis. And sometimes it's important to harbor a sense of uncertainty is important, or
Absolutely.
uncertainty is necessary.
Uncertainty, curiosity, I'll speak for myself, I will rarely ever just accept a prior diagnosis the patient is entering my visit with. It is our job to do our own evaluation and assessment and get diagnostic clarity as to what is going on.
Agreed.
Yeah. Now, let's turn to some audience questions. Okay, this is a question I receive all the time. If I have a loved one who is in a manic episode and has no insight into the fact that they are currently sick and in an episode and is engaging in destructive behavior and jeopardizing his own life and the lives of others, how can I get this person help?
And I think that is one of the hardest scenarios for a loved one to be in. You have this person that you care about so much. You clearly see concerns. There clearly is a huge discrepancy in terms of the way they feel versus the way you feel. In cases like this, I think it is important to get people immediate help. You can certainly call 911. You can certainly take somebody to the emergency room, make sure they get, an urgent psychiatric evaluation. And this can be very painful for many loved ones because, certainly if, the patient objects, if they don't feel the same way, it can be very, very delicate to encourage them to see a doctor when they don't want to. But on the converse, what I can say is, many people, when they're in periods like this, they do engage in behaviors that, are very permanently damaging. In many patients, when they're helped through these periods of time where they're brought to the hospital, where they're offered treatment, when they accept treatment, many people do improve. Many people do get much better, and sometimes it's not until somebody gets much better that they realize how sick they very much were.
Yeah. It's a very difficult situation because oftentimes the family and friends, they feel helpless. And unfortunately, there's a lot of times where there's no helping this person. They are so convinced, they're so out of touch with reality. They can't accept when you show them evidence of the problem and the damage they're causing, that unfortunately, a lot of times you just have to wait for the mania to get extinguished and the damage has already been done. But like Pat was saying, even if you have to involve emergency services, because this is an emergency, people can engage impulsively, they can have a big increase in their tolerance for risk, and they can, their life or livelihood can be in jeopardy. Certainly. But it is amazing how effective medications can be in treating acute mania. There is absolutely hope that if you involve emergency services, which can be very difficult, of course, that once medicated, even in a few days, let's get him sleeping, let's get a mood stabilizer in him, let's titrate it up quickly, let's get him into some sort of safe environment where he can't jeopardize his or other people's lives or her, that there is absolutely hope that this can be managed and treated in the acute setting. But the barrier there is getting the person to accept treatment. And if you have to involve emergency services and perhaps treat them against their will, despite the acute pain and you feeling like you might be betraying your loved one, that can literally be a life-saving approach.
And it often is critical, and if you find yourself in a situation where, yourself or a loved one is in the scenario where, you have symptoms of a clear mania, you're spending large sums of money, you're engaging in self-injurious behavior, assaultive behavior to others, or acting in other ways that are damaging, it is critical to get help immediately.
Absolutely. Can someone with bipolar disorder be treated with classic antidepressants like SSRIs?
They certainly can, and oftentimes people are. So you mentioned before, many people with bipolar disorder may need multiple medications to manage their symptoms, whether it's a mood stabilizer that helps kind of keep people in states of euthymia. By that I mean places where, you're not manic, you're not hypomanic, but you're not depressed. That can be critical. Antidepressants are helpful in terms of helping people through the lows. And some of the antipsychotics may be very necessary to help people through periods of manias, especially when they have symptoms of psychosis. If they develop false thoughts about things that are not going on, if they develop perceptual disturbances, hallucinations, by that I mean hearing voices, seeing things that are not there. If people are, developing significant feelings of fear and isolative behavior, there is a place and time potentially for all these classes of medications. We know that many people with bipolar disorder unfortunately spend many of their episodes with depressive symptoms. And traditionally there is a fear that using antidepressants alone may risk somebody precipitating a mania or a hypomania. Certainly not to the same degree of using a stimulant medication for ADHD, but we still see that as a potential risk. So usually what is considered good form is to have somebody adequately mood stabilized, whether that's by lithium, any of the anticonvulsants such as valproic acid, lamotrigine, oxcarbazepine, carbamazepine, or an antipsychotic at a good level before you add the antidepressant. And having an antidepressant, in addition to these medications, can be tremendously helpful for many people and is something that is, certainly within the scope of what is good care.
Yeah, and I would agree with you. If a patient has bipolar, and the literature supports this, certainly I would not introduce an unopposed SSRI, meaning this person has bipolar, let me treat the depression with the Prozac, Zoloft, Lexapro. I would never do that. The evidence shows that that can be damaging. It can cause turbulence in mood. If you have an adequate mood stabilizer on board, meaning one of the medications you mentioned at a therapeutic level, then you can bring a traditional antidepressant like an SSRI or Wellbutrin and hope and expect that it might be therapeutic and helpful. So if you have bipolar, can you use antidepressants? Yes, but you want to be adequately mood stabilized before you bring it in, or else you're going to risk turbulence in mood. And there's actually, as far as I know, no evidence for treating major depression in a bipolar depression with an antidepressant like an SSRI unopposed. You always need a mood stabilizer on board.
Yes, and that's typically, a good form. And I think oftentimes it can be challenging to make the diagnosis again of bipolar disorder, because maybe people will come to you with symptoms of depression and maybe their symptoms of hypomania won't be identified or won't be reported, or there may be a narrative of, significant, stimulant use. So sometimes it can be really challenging if you don't see people during their periods of their manias, or if you don't have, a clear sense of their history. Sometimes people are not very good reporters of their own symptoms historically, and sometimes you just don't know. Yeah. So it can be challenging, but when in doubt, I think if you suspect that somebody, may have a bipolar diathesis, by that I mean historical symptoms of a mania or hypomania, is to get them in a place where you adequately mood stabilize them first.
Yeah. And the challenge with bipolar is that, I forget the exact number, but a large percentage of patients that have bipolar are misdiagnosed for like this first 6-7 years, because what's most prominent is the clinical depressions.
Certainly.
They have their hypomanias, but it gets confused like, hey, doc, I was just not depressed. I was so happy things were going right and I wasn't depressed, so I was functioning super well. It gets classified as a major depression, not a bipolar depression. They get treated like they have unipolar depression, so major depression rather than bipolar depression. And it's not until later where a mania or a hypomania presents itself in an obvious way that they're actually able to be confirmed and diagnosed with bipolar and treated accurately. And so that is the challenge, is that oftentimes it takes years to accurately diagnose bipolar, because what has been most evident is the major depressions, the hypomanias just get brushed off like, hey doc, I'm just not depressed, things are going well, I'm doing super good, and I'm super functional. But it's not until later where the mania or the hypomania presents itself that you can diagnose accurately and then treat accurately.
And that's often a clinical consideration. I think it's good form for anybody who, potentially is starting on a, traditional antidepressant, anybody that I'm seeing in the office and you presume they have a unipolar major depressive disorder, is that you do caution them, about some of these symptoms. If you experience, periods where you're not sleeping well for days at a time, if you're not feeling the need to sleep, if you're feeling unusually irritable or euphoric, if your friends are commenting that you're talking a lot, if you're engaging in unusual risk-taking behavior, if you're unusually productive, these all could be warning signs. I think that is an important conversation to have, off the bat, and give people a sense of, what kind of symptoms they should be, kind of keeping in mind.
Absolutely.